Welcome everyone to today's webinar. I am Mackenzie Dean with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, I want to thank our webinar sponsor, Imprivata, and introduce our presenters. Dr. Michael Redman is an otolaryngologist, fellowship-trained head and neck surgeon, and Chief Medical Information Officer for Gundersen Health System. Dr. Redman has a bachelor's degree from the University of Dayton, a medical degree from the University of Chicago, completed his otolaryngology head and neck surgery residency at the University of Chicago, and completed his head and neck fellowship at Rush Presbyterian St. Luke's Medical Center in Chicago. Amy Lowe's is a clinical informaticist on the EPIC ambulatory team for Gundersen Health System, where she is responsible for various topics, including e-prescribing. Prior to working on the ambulatory team, Amy was a float nurse in the hospital at Gundersen and worked at Rochester Mayo on a hematology-oncology floor. Amy was an EPIC trainer for Gundersen for the inpatient go-live in 2018 and then joined the ambulatory team prior to the go-live in 2011. Amy has a bachelor's degree in nursing from Winona State University. I am also pleased to be joined by Dan Borgesano, the Director of Product Marketing for Imprivata. Amy, I'll now turn the floor over to you.
Thank you. All right, thank you, everybody. I'm just going to give a little background about Gundersen Health System. Our main hub location is in La Crosse, Wisconsin. We are a approximate 325-bed teaching hospital with 30-plus clinics that are kind of spread out in the Iowa, Minnesota, Wisconsin areas. We are currently working on our latest conversion to Gundersen clinics too. We have about 7,000 employees. That includes 540 medical staff and 342 associate staff with about 16,075 annual admissions. Next slide, please. A little history about our EPIC go-lives. We implemented EPIC Inpatient back in 2008. When we did that, e-prescribing was turned on at discharge for all of the non-narcotic medications. We then went live with EPIC Ambulatory in 2011 and then turned on refill locations, which we hadn't had with inpatient. There was no single sign-on implemented at this time. They used their employee ID and password to sign into EPIC and other applications. Our first introduction with the Imprivata use was for anesthesia on our anesthesia carts in 2014. We started using single sign-on. Shortly after then, in the fall of 2015, we started looking at having single sign-on everywhere else, and then also implementing e-prescribing controlled meds. We had waited until the bigger pharmacies in our area, like the Walgreens, Walmarts, Targets, were all able to accept e-prescribing of controlled meds before we decided to roll out, because we didn't find a huge benefit to it prior to that. We did a system-wide rollout of both single sign-on and EPCS in the winter of 2015 and spread it through the end of 2016. Next slide, please. As I'm sure many of you are already aware, there's just some burdens and challenges with printing off the paper prescriptions. Prior to 2011, we did print all of our narcotics on paper. A couple of things that came to mind when we were putting together this presentation and coming up with reasons that we would move forward with this project is just the burdensome for patients who need to travel. We have a lot of small clinics, and sometimes patients travel in an hour or two to get their prescriptions every month. So that was a key patient satisfaction thing for us. Physicians know the patients. They want to be able to refill prescriptions electronically, help those patients out. We also had our prescriptions printed in centralized stations, which introduces the risk of theft. I think we've probably all walked by printers that had prescriptions sitting on them. And then just the inefficiency, dual workflows created frustration for providers and patients. Nursing staff would print out these prescriptions, have to go find the provider, patients would have to come in. So there were a lot of items that we thought we would benefit from. Next slide, please. So Gundersen's solution for the issues or burdens we had seen was to then implement single sign-on and EPCS together for a variety of reasons. We chose Imprivata, and then we decided this would be a seamless Epic integration, one single platform to implement and manage. The implementation process could be very similar for both single sign-on and EPCS, and consistent administration and reporting, and then the end-to-end solution for meeting the EPCS compliance requirements. Next slide, please. The project was driven by IT in partnership with hospital and clinic leadership. We had a very large team. I co-managed the project with another analyst who's no longer at Gundersen, but we had a lot of people involved. We had providers involved. We had directors involved. We had server engineers, system engineers, lots of different clinical and hospital leadership just to help us try to make this the most efficient as we could. We included our manager meetings and just lots of other teams, pharmacy teams, and I'll get more into that too in a bit here. Next slide, please. So some of the regulatory considerations that we had to really take a look at prior to our go live was identity proofing and credentialing of providers. So making sure the provider said who they were who they said they were, having credentialing involved in that process, making sure each new piece of the step was a new individual approving that provider to be set up. So that would be bullet point number 2, enabling permissions, and Epic had to be a couple of different people at each step. So that was probably coming up with these workflows and figuring out the regulatory considerations were definitely the hardest part of this project. Two-factor authentication was another piece we had to figure out, and then the auditing and reporting piece, who would view the reports, what we would do for reporting, things like that. Next slide, please. So we used, one of the big decisions when you first go live with this project is just deciding if you're institutional identity proofing, which we did through our credentialing office, assigning administrators to facilitate the supervised enrollment. So we decided to move forward with fingerprinting. So having staff in place that would help us enroll all of the providers' fingerprints, and then requesting EPCS authorization for providers within Epic. So one person to set up their SCR with the functionality and another individual to approve that. So really figuring out those steps prior to our go live was key for our success. Next slide, please. So a couple of considerations. The DEA requires two-factor authentication at the time of electronic prescribing. So 2 of the following, token, password, or fingerprint. We moved forward with password and fingerprint for EPCS, and then the proximity badge for single sign-on. So where you put your badge up to the reader and it signs you in. Next slide, please. And then coming up with a implementation plan in scope for us was installing the single sign-on and EPCS at all the ambulatory, inpatient, regional ambulatory, and affiliates. And then having the devices placed on all workstations that utilize patient care computers. So we really took a look at who was taking care of patients, who would benefit from these workflows. So out of scope would be the remote EPCS, non-patient care areas, and then other non-Epic clinical applications. And you can see we had Visios to kind of walk us through what we would do for our implementation and tying those pieces together. And then every day we had this just replay, so we knew where to go live with. I think part of the implementation plan too that's key is that we met with managers to really make sure that they knew that communication to their staff was key for both of these as they'd come in that day and see new devices in place. So we made sure that they were communicating to their staff ahead of time and letting them know what they needed to pass along to their staff. Next slide, please. So here was our project rollout. We started with our Onalaska clinic, which is where most of us are stationed. And then we moved to La Crosse, and we just had we had all of these steps that we just had replay for each location, and we went floor by floor, plugging in devices. Obviously, our clinics were a lot easier because we have off hours, so we didn't have to go into rooms that had patients in them. Next slide, please. And our results following our go live of our last clinic location, we did see a significant reduction in paper. Gundersen does not require that we prescribe these medications at this time, but there was a huge buy-in. We had a 7 times increase in 4 months. Current state is definitely over 80%, and we have improved provider workflow efficiency, increased patient satisfaction, and reduced risk of prescription theft or fraud. And we definitely have had providers reach out to us and let us know some pretty great stories of why this has helped their hospice patients who haven't had to come in during snowstorms and things like that. So that was a huge win for all of us. Next slide, please. Some tips for success. Communication is essential. This project turned out to be way bigger than most of us had anticipated, and knowing who needed to be involved. Like I said earlier, to developing that comprehensive rollout plan. So starting with, these are the steps that need to be rolled out at each location, and just having that reoccurring rollout plan that just worked for each location. So it just reset itself. We had a game plan, everyone knew what their role was, and we knew what we had to do at each location. Ensure consistency and device placement. So prior to our go live, we rounded in the hospital, we rounded in the clinics with directors and providers, and really got a feel for where it would make sense to put each of the devices, and where it wouldn't make sense to have them. We figured out where the providers would be sitting so that we made sure we had a device with a fingerprint reader in it. Just understanding the complexity of the project, this was a huge undertaking for our staff and involved getting more people on board as we got deeper into the project. And then delegating responsibilities. Teamwork is key. Having everyone on board trying to make this a successful project was definitely key. And then lastly, conducting pharmacy outreach before go live. We're a little farther down the road, so this might not be an issue for some locations, but we were the first in our area to go live with EPCS. So we did have pharmacies, even though I had reached out to several of them prior to our go live, we did have pharmacies deny scripts to patients even when patients drove into the pharmacies, because the pharmacies didn't think they could accept the prescriptions even though they were set up. Their communication between their vendor is a lot different than just our internal Gundersen network. So I did do a lot of reaching out to them, making sure they understood, and a lot of education. And like I said, we had some denials, and then I had to explain the process, explain that they were allowed to accept those in Wisconsin and Minnesota and Iowa. So that was a huge undertaking too. Next slide, please. What's next? As you are probably all aware too, there's been a lot of talk about opioid abuse in all over media, and we're seeing webinars and more education. So there's never going to be a point where I don't think there'll be any less reporting that we'll have to do for EPCS, because it'll always be reaching to do better and provide care to our patients better. And then enabling remote EPCS access. We have done some work with authenticating and using an Imprivata push token. We did have probably just a handful of providers, maybe 10 to 15 providers whose fingerprints really didn't work well with the Imprivata devices. So we did move forward with allowing them access on their phones, which has worked great for those providers. Next slide, please. I think I'm done. And I didn't have anything further.
Great, thanks, Amy. This is Dan Borgasano with Imprivata. Thank you for providing that overview. So that's really sort of how Gundersen went about implementing single sign-on and electronic prescribing for controlled substances and some of the key considerations. So I'll go through now Imprivata Confirm ID quickly, which is the solution that they used. And so if you go to the next slide, Confirm ID is really designed to be a complete solution for helping you meet all of the DEA requirements for EPCS while also ensuring a fast workflow for your providers. And so Amy touched on some of these requirements, but there's an identity proofing where you need to validate the identity of all of your providers who will be doing EPCS. As part of that, you really want to bind their two-factor authentication credential to their identity, so you know exactly which approved providers are using what methods of authentication for EPCS. There's also a parallel track, logical access control is how the DEA refers to it, and that's really setting the permissions to access the EPCS workflow within your EHR or your e-prescribing application. Now within that step, the DEA requires two individuals, one to actually configure the system and set those permissions, and then another to go in and actually approve those. And there needs to be a separation of duties between the identity proofing and the logical access control. As Amy mentioned, there is a two-factor authentication requirement at the time of prescribing, and then a host of reporting reporting requirements that you have to meet the DEA requirements. And so Confirm ID is really designed to help you meet all of those steps. And you can kind of see here all of the points in the entire DEA EPCS process where Confirm ID can come in and help you meet these steps in an efficient way, but also give you a complete end-to-end audit trail so you can prove and show that you've met all of the different steps. If you go to the next slide, one of the ways in which we do this is through a utility that allows for that identity proofing as well as supervised enrollment of the provider's credentials. So the DEA allows two types of identity proofing for EPCS, individual and institutional. Individual is where each individual provider will go to a third-party credential service provider or CSP website and enter a series of personal, financial, demographic information to validate their identity, at the end of which they'll be issued a two-factor credential. The other method is institutional, and that's what they use at Gundersen and many other places. This is where if the organization itself is a DEA registrant, what the DEA refers to as an institutional practitioner, then the DEA allows you to conduct this identity proofing step in-house, typically through the credentialing office. And that's what this utility is designed to help you do. So you can assign enrollment supervisors within the Confirm ID product. And these are the folks that will be charged with actually checking the ID of each provider you want to give EPCS to. At a minimum, it must be a government-issued photo ID. And they can make a record of it here in Confirm ID, and then they'll authenticate to validate that transaction. Immediately thereafter, they can help the provider enroll whatever methods of authentication they'll use for EPCS. So in this example, we have fingerprints, but the provider can also enroll their phone as a token for things like push token and hands-free authentication, which we'll talk about. And this can all be done in a matter of minutes. The identity check, the record capture of that, as well as the enrollment of the provider's credentials. And so not only will you satisfy a couple of steps in the EPCS process, you'll create a record of it, but by having that supervised enrollment of the provider's credentials, you'll make sure that they can enroll their fingerprint, enroll their phone correctly and quickly the first time, and that really get them off to a good experience with EPCS right out of the gate. So you go to the next slide, please. So as I mentioned, one of the steps required for EPCS is logical access control, and that's where, again, you'll set the permissions within your EHR to give those approved providers access to the EPCS workflow. But before it can actually be activated, a second individual needs to log in and authenticate that those permissions were given to the correct list of providers. And that's what we call EPCS access approval. Within Confirm ID, you can also assign the role of EPCS access approver. And when they go through this approval process within your EHR, the product will call out to Confirm ID and ask for an authentication, and that will capture a record that this very important approval process did take place, and you'll have an audit record of that in the same system that you have the records for identity proofing and two-factor authentication. Go to the next slide, please. So in addition to those sort of back-end pieces, Confirm ID also supports a broad range of two-factor authentication options. The idea is really, we know that if you put a two-factor authentication requirement in front of your providers, it may run the risk of being a barrier to care and may potentially make what is an inefficient workflow something even worse. So we want to try to give you the flexibility to use whatever combination of two-factor authentication credentials is going to best meet your provider's needs in any different prescribing scenario. So at the time of prescribing, the DEA requires two of these three things: something you are, like a biometric, something you have, which is most often a token, and then something you know, which is a password. Confirm ID supports all of these different methods, and again, they can be used in different combinations. So that will give you flexibility to use whatever options that will best meet your workflow requirements. It's also going to give you backup options in case your provider doesn't have their phone, for example, as a token. They can revert to password plus fingerprint biometrics. And having that backup is going to be especially important as more and more states start to mandate EPCS. There are now 10 states that have passed requirements for e-prescribing for controlled substances. 3 are currently in effect. 7 more will come online in the next couple of years. In addition to which, there are about 10 to 12 more states that have introduced legislation, and there is even a bill at the federal level that would mandate e-prescribing of controlled substances for all patients in the Medicare Part D program. So when paper no longer becomes a valid backup option, it's going to be really important to have different methods of authentication available so that your providers can complete that EPCS process and be compliant. And Confirm ID will manage on the back end whatever methods they have available and allowed for use in any given scenario, and will only present that provider with whatever methods are fast and efficient at that time. So for example, if you're using fingerprint biometrics as well as the phone as a token, but a provider is prescribing from a workstation that does not have a fingerprint reader, the product will recognize that and it won't ask them for their fingerprint. So the provider will never have to worry about which authentication methods to use. They'll, again, always only be presented with the most efficient combination available at that time. Go to the next slide, please. So a couple of the different ways we can make this even faster process is the way that we deliver the token. So many of you may be familiar with a conventional one-time password token, either a hardware key fob or an application that runs on a mobile device, and it generates a unique 6-digit number every 30 seconds. Now, traditionally, that number is manually typed in to whatever application and used as the second factor. But we really want to make it as efficient as possible. So Imprivata has introduced a couple of different ways that token can be delivered. The first of which is what we call hands-free authentication, and this will actually happen automatically. So the provider will complete the EPCS order in the EMR, and then they'll enter their first factor of authentication. In this example, it's fingerprint biometrics, but it could be a password. Hands-free authentication will then automatically authenticate the second factor. It will look for that provider's phone and authenticate that token that's running on a mobile app without the provider having to unlock their phone, open the mobile app, and type over that 6-digit code. The provider doesn't even have to take the phone out of their pocket. It can be locked, and the hands-free authentication will authenticate as a second factor, and the order will be sent. So you can see the combination of fingerprint plus this hands-free authentication allows the provider to complete two-factor authentication simply by putting their fingerprint down. And we see this used in high volume areas, maybe the ED, certain discharge stations, and certain other departments or orthopedics perhaps, where there is a high volume of transactions and you really want to put the fastest, most convenient option for your providers. If you go to the next slide, we have another option that's very fast, not quite as fast as hands-free, but still much more convenient than needing to type over that code, and that's a push token notification. So here, after the provider enters their first factor, again, a password or fingerprint biometric, Confirm ID will send a notification to that provider's phone, and you can see here, right from the lock screen, they can simply approve that request, and they'll be authenticated. So again, not completely hands-free, but still far more efficient than needing to unlock the phone, open up the application, and type over that code. And that combination of a password plus that push token really enables EPCS anywhere because there's no additional hardware required at all. And again, once states and maybe even federally, they start mandating e-prescribing for controlled substances, that combination is going to make it fast and easy for providers to meet that requirement from wherever they may be prescribing. If we go to the next slide, there's also a host of reporting components. So if you've looked at the DEA interim final rule governing EPCS, then you know there are a number of different requirements for reporting and record keeping, and Confirm ID will help you meet all of those, from the identity proofing to the enrollment of credentials to that EPCS access approval, and then the transaction itself. What methods of authentication were used, from what endpoint, by what provider, was it a successful transaction or did it fail, etc. And in combination with the reports that you'll generate from your e-prescribing or your EHR solution, you'll be able to have a comprehensive audit report to meet all of the DEA requirements. And in certain cases, certain states may have different record retention laws. For example, you may be familiar with New York's I-STOP law, which took effect in March of 2016. That was the first state to mandate EPCS, and they had record retention requirements that were a little more stringent than what the DEA requires. And so Confirm ID can be configured and customized to meet your state's individual needs should they differ from, again, the DEA requirements. We go to the next slide. And so finally, we know that there are many use cases for two-factor authentication, multi-factor authentication, beyond just EPCS. And ideally, you want to be able to give your providers a single method, a single token that will allow you to enforce two-factor authentication for all these different workflows without having to give them multiple solutions for multiple things. So while we've been focused primarily on EPCS, Confirm ID really is designed to be an enterprise multi-factor authentication platform to allow you to extend and enforce second-factor authentication to a number of different workflows. Things like remote network access through your VPN, access to cloud applications, other clinical workflows like attestation of anesthesiology and a number of others, and even authentication to medical devices. All of this is done from the single centralized platform that is Confirm ID, which not only is easier to manage and audit reports, but also it's going to give the users a familiar, fast experience across all of these different workflows. So I think with that, I'm done, and we'll turn it back over for questions.
Thanks so much. And Mackenzie, we'll turn it over to you for questions.
Great. Thank you, Amy, Dr. Evan, and Dan for that fantastic presentation. We will now begin today's question and answer session. Please submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We will try to get through as many questions as we have time for. So we already have a lot of great questions rolling in, and the first one is, can you please repeat the reasons for needing two separate people, one to set up EPIC access and the second to do what? This audience member would just like some clarification on that process.
This is Amy. We just looked through the regulations. We really involved compliance and legal at that time, and they kind of just put out on paper, told us what kind of requirements they understood from the regulations. So our process here at Gundersen was to have someone get the fingerprints of the provider after credentialing, added them to a share site. One person updated the SCR with the new e-prescribing controlled med settings in their SCR, and then granted them access via their SCR, and that part of EPIC's workflow then is to send an in-basket message from that granting access that another person has to approve. And like I said, we really involved our legal and compliance to help us understand those regulations for what Gundersen would need on our end.
Great,
Yeah,
thank
and
you so much.
since you're asking about EPIC specifically, there is an EPCS access approver role within EPIC, and as Amy mentioned, it's managed through the in-basket, and it's a very easy process once you assign that role to who those approvers are, but that is a DEA requirement. And one other thing I just wanted to mention is that the requirements for who can be that access approver, that second person, differ depending on how you do the identity proofing. Whether you do the individual or institutional that I mentioned will determine what you're required to do for that EPCS access approval. So we can definitely follow up with you and talk about that in a little more detail.
Wonderful. Thank you both for elaborating on that. It looks like the next question is for Amy, and it says, does Minnesota have a requirement that a provider needs to access a prescription database prior to EPCS?
Dr. Redmond, you might know what the requirements are for the EPDMP site, but we do require that our providers, we have a BPA that fires, and the providers have to check the site prior to e-prescribing.
Yeah, this is Mike Redmond. I think from our standpoint, and we're mainly based in Wisconsin, is we check the PDMP in the state of Wisconsin. I have not needed to check prescribing in Minnesota or in Iowa that I know of.
Great, thank you both for touching on that. Dan, it looks like the next question is for you, and this audience member says, can you please elaborate on the specific requirements an organization must meet to be allowed to conduct institutional identity proofing?
Sure, no problem. So if the organization itself is a DEA registrant, and that's what the DEA refers to as an institutional practitioner, meaning there is a DEA number, again, assigned and registered by the organization itself, which is required to administer controlled medications on site, then the DEA gives you the authority to conduct identity proofing in-house. And we've typically seen it done through the credentialing or the MSO office. And the DEA is basically saying that these organizations are already trusted agents of the DEA, and you also have robust onboarding and credentialing processes already, where when providers are coming on board, you check their background, you check their medical license status, you may check their DEA number status, whether they're allowed to prescribe controlled substances, etc. So because you already have these processes in place, the DEA is giving you the authority to conduct the identity proofing specifically for EPCS. However, a common question we get is, well, given all that, do we actually have to identity proof our existing providers if they're already doing controlled substances on paper today? And the answer is yes, you do need to validate their identities before you can give them access to EPCS. It's a minimum photo-issued government ID, and that must be done in person. So it can't be done remotely or via a website like you could do with individuals. The product Confirm ID, as I said, does have a utility to allow you to do that and make it a little easier, but you do need to physically check government-issued photo IDs of each of those providers, and it does need to be done in person.
Great, I think that's really helpful for our audience to understand. Amy, the next question is going to be directed to you. This audience member would like to know, did you have any Did you have any providers that refused to use their fingerprints for the process versus it just not working for them?
Yes, we did. We didn't have very many, but we had, I'd just say probably a handful that refused to put their fingerprint on anything because of all the identity theft issues out there, even though we reassured them that it was not possible because of how Imprivata was built. But because it wasn't required at that time, we didn't push it.
Wonderful. Thank you so much, Amy.
Mm-hmm.
The next question is, has Imprivata implemented with Cerner EMR? Dan, why don't you take that one?
Sure. So, we've been talking about Epic because that's what Gundersen uses, but certainly Confirm ID integrates with a number of leading EHR systems and e-prescribing applications, including Cerner. And certainly if you have any specific questions about your environment and the versions of software that you have, please reach out to your Imprivata representative and we can discuss that with you.
Great, thanks, Dan. So the next question is, for Amy or Dr. Redmond, and the audience member would like to know, how did you go about educating physicians about EPCS and getting them to enroll?
We really utilized our managers. Like I said previously too, we set up meetings with them every week, and we broke them out into groups. So by floor, we'd meet with one group 1 week, tell them their go live dates a couple weeks out, and we would really push the education to the managers and really passing that along to the providers. We did give them all a very nice guided practice. The workflow for using Imprivata for EPCS is very easy to follow, even if the providers wouldn't have had education. So we reassured them how easy it was. They just stepped through the process. They click the next button and put their fingerprint and their password in, and they are good to go. But like I said, if managers felt that there was some more education needed in their department, we did go to a couple of departments and show them how it worked. But the guided practice really was all we needed for education, as long as that was passed along to the providers.
Wonderful. Thank you so much for elaborating on that, Amy.
Absolutely.
So the next question is, how did you get 80% of the providers up on using EPCS without it being a CMS requirement? And Amy, maybe you could answer that one as well. Thank you.
I can chime in,
Redmond.
Amy. Yeah.
Perfect.
Mike Redmond, this
you.
is by far a huge benefit for practicing physicians, especially like I'm a surgeon. So we would write prescriptions, they would get lost, misplaced, whatever. And with doing this is, it's in my workflow. We e-prescribe as much as we can. And once we got in fact, I was part of the pilot to at least tested me and a handful of providers and surgeons. And when this got spread amongst by word of mouth throughout the entire community at Gundersen, everybody was like clamoring to jump on this. They wanted it. Don't you think so, Amy?
Absolutely. And we had providers asking for a really long time when we would move forward. So we had to, because they knew the regulations had changed. So we really had to explain to them that we had to wait until more pharmacies were on board. And by the time that came around, we had a lot of providers just really ready for it. And I had a voicemail one day when I came to work that this was the best invention since sliced bread. So we have a lot of patients who travel in. Our hospice providers were very grateful that families didn't have to travel to the clinic before going to the pharmacy, and just everyone has been so grateful, and so grateful for the workflow and grateful that this helps their patients out, that we haven't had to push it or require it at all.
Wonderful. Well, thank you both so much. Looks like that is all the time that we have left for today. So I would like to thank Amy, Dr. Redmond, and Dan for their excellent presentation, and to our audience for participating today. Please enjoy the rest of your day, and we look forward to having you join us for future webinars.